Applying standard adult cardiovascular baselines to an infant can easily lead to misdiagnosing healthy physiology as a medical emergency. A pediatric heart operates under mechanical and developmental parameters that shift significantly throughout childhood. This graph maps the shifting normal limits for heart rate and systolic blood pressure. Notice the steep drop in the heart rate line. A newborn can sustain 205 beats per minute, while a 10-year-old peaks at 100. Systolic blood pressure follows the opposite trajectory. A healthy term newborn operates between 60 and 95 millimeters of mercury, a reading that indicates severe hypotension in a 5-year-old. To map these shifting hemodynamics, we use the IPPA framework: inspection, palpation, percussion, and auscultation. Each physical finding requires interpretation against the patient's chronological age. A pulse or pressure reading that represents health in a toddler may signal a crisis in an older child. The pediatric exam requires calibrating expectations to the developmental stage to ensure the mechanical and acoustic signals match the actual physical maturity of the heart. This grid maps the chest wall as a coordinate system, plotting findings using intercostal spaces and the mid-clavicular line. Anatomical landmarks migrate during growth. In an infant, the apical impulse sits at the 4th intercostal space, but drops to the 5th by age 7. Moving to the neck, the internal jugular vein acts as a manometer for right atrial pressure. It lacks valves and maintains a direct fluid path to the right atrium. With the child at 45 degrees, a normal jugular venous pressure sits under 4 centimeters above the sternal angle. Measurements above this indicate volume overload or structural obstruction. This waveform graph tracks the right atrium's mechanical phases. The A wave represents atrial contraction, while the V wave marks venous filling against a closed tricuspid valve. An abnormally large A wave suggests the atrium is straining, a marker for conditions like tricuspid stenosis. Inspection allows the examiner to read the body's external gauges to measure invisible right heart pressures. Palpation translates internal flow and chamber size into tactile data, mapping hypertrophy and turbulence through the chest wall. This cross-section shows how hypertrophy distorts cardiac shape. Left ventricular hypertrophy expands downward and laterally, while right ventricular hypertrophy pushes purely laterally. This axis of displacement identifies which ventricle is under stress. The character of the impulse reveals the underlying pathology. A hyperdynamic impulse, felt over multiple intercostal spaces, indicates a volume overload, such as mitral regurgitation. A heaving impulse presents as a sustained, forceful thrust. This signals a pressure overload, where the ventricle struggles against high resistance, typical in aortic stenosis. A parasternal heave, felt with the ulnar edge of the hand, serves as a marker for right ventricular hypertrophy or left atrial enlargement. Severe internal turbulence generates thrills, palpable vibrations that confirm the presence of an organic murmur, classified as grade 3 or above. Palpation transforms volume and pressure overloads into localized, measurable mechanical thrusts against the hand. Auscultation focuses on fluid acoustics, using sound to track valve closure and blood flow patterns. These 5 auscultation zones are listening posts where acoustic frequencies naturally radiate. Erb's point at the 3rd left intercostal space optimally captures murmurs of ventricular septal defects. Gibson's area, lateral to the 2nd left space, detects the continuous murmur of a patent ductus arteriosus. The first heart sound, S1, marks the onset of ventricular systole as the mitral and tricuspid valves close. The second heart sound, S2, marks the start of diastole as the aortic and pulmonary valves shut. Placing the stethoscope at these precise coordinates isolates the distinct fluid signatures of specific anatomical defects. In children, S2 splits into aortic and pulmonary peaks, widening during inspiration. A split remaining unchanging is a fixed split, the hallmark of an atrial septal defect. In severe aortic stenosis, the aortic valve closes late, resulting in a reverse split. A third heart sound, S3, occurs during early diastole. In adults, this often signals failure, but in healthy children and athletes, it reflects the rapid ventricular filling typical of the age. A fourth heart sound, or S4, appears just before S1 and is a pathological finding in any pediatric patient. An S4 gallop indicates the atrium is forcing blood into a stiff or failing ventricle. timing and splitting variations provide millisecond-level data regarding chamber stiffness and valve sequencing. Clinical diagnosis requires the integration of all IPPA steps to solve a complex constellation of physical signs. An elevated JVP V wave, a heaving apex, and a fixed S2 split are pieces of one puzzle. They converge. The split identifies an atrial septal defect, while the venous wave and apex verify volume overload and right ventricular hypertrophy. None of these signs can be accurately interpreted against an adult baseline. Clinical accuracy requires the examiner to recalibrate mechanical and acoustic expectations against the patient's age. The pediatric cardiovascular exam converts external tactile and acoustic clues into a precise three-dimensional model of internal hemodynamics,